Hi, this is Dr. Poole from the Department of Pathology, and I'm going to cover general features of benign and malignant neoplasms. So one of the key questions is, how do pathologists tell whether a tumor is benign or malignant? There's no magic or some special secret knowledge that we acquire going through pathology residency, but the consistent application of general principles as we look at different neoplasms and determining whether they're benign or malignant. So that's what I'm going to share with you. So one of the first hallmarks of neoplasia is differentiation, meaning the extent to which neoplastic cells forming a mass resemble corresponding normal cells or tissue from the same organ. So benign tumors form a mass, but these closely resemble normal cells or tissue, so they don't deviate too much in their appearance from normal tissue. So let's look at an example. So this is a smooth muscle neoplasm of the uterus, which we call a leiomyoma. And in this image, the leiomyoma is on the left. And you can see, which I've drawn over with the red line, of course, that it forms this sort of bulging mass going into the surrounding normal myometrium, which is on the right. So let's look at a little bit higher power and see how they look the same and different. So this is the leiomyoma, and we can see that it's composed of these cells that are fairly uniform in size, shape, and appearance. They form these elongated, slender cells with ovoid nuclei, and the chromatin in the nuclei is relatively evenly dispersed. Now let's compare it with normal myometrium, and you can see that although the cell density is a little bit different, there's more cells per unit area compared to the leiomyoma. When we look at normal, the nuclei look very similar. They have these elongated shapes and elongated ovoid nuclei. The chromatin looks similar. So except for the fact that the leiomyoma forms a grossly visible mass, microscopically they look fairly similar in appearance. In contrast, malignant tumors show a wide range of deviation in appearance from normal tissue and cells. So they not only form a mass, but they stand out histologically from surrounding tissue. And we use modifiers well, poorly, or moderately differentiated to describe the extent of this deviation in appearance from normal tissues and cells, or the extent of differentiation. And this is called the histologic grade. And so we pathologists use quantitative or qualitative histologic criteria to try to reproducibly define the differentiation of a tumor type and hopefully correlate this with clinical behavior, meaning that grade 1 or well-differentiated tumors will behave better than grade 3 or poorly differentiated tumors. Sometimes we collapse these the lower grades, grade 1 and grade 2, into general low grade versus high grade or grade 3 tumors. The term anaplasia refers to a complete lack of differentiation, meaning that the neoplasm shows no resemblance to any recognizable normal cells or tissue. And so we pathologists have to use other diagnostic tests to further characterize the tumor. So we may use immunohistochemistry using labeled antibodies to identify different protein signatures that are expressed, and we do this on tissue sections. We've seen a little bit of this in previous courses. You can use in situ DNA or RNA hybridization to identify molecular targets that are associated with a diagnostic tumor type. And similarly, you can do genetic testing on DNA or RNA that's extracted from tumor cells to identify specific genetic changes that may be associated with a particular tumor type. Another important hallmark of neoplasia is that the spatial relationship between cells is disordered, meaning that normal epithelial cells, as you've seen in your histology labs, are organized into a regular, recognizable arrangement between each other, and that's how you can recognize, that's one feature you can use to recognize normal tissue. Cells that are lining viscous, hollow viscous, like the intestine, the cells are organized in a way that there's a polarity to the cells, meaning that usually the nucleus is located toward the abluminal portion of the cell, while the cytoplasm is located more toward the luminal aspect of the cell, the inside of the viscous. And when that polarity is lost, that's a feature of neoplasia. And malignant cells grow in a disorganized pattern, meaning that the cell relationships are all jumbled up and there's a loss of normal cohesion and two-dimensional and three-dimensional organization of the tissue. Another similar feature to this is pleomorphism, meaning that normally terminally differentiated cells are uniform and regular in size and shape. So if you look at a section of intestine, for example, one enterocyte looks like the next one, which looks like the next one, etc. Whereas what we see in neoplasia is that the cells show a lot more variation in their size and shape. Another hallmark of neoplasia is abnormal nuclear morphology, and there's several components to this. One is increased nuclear to cytoplasmic ratio. So normal cells have a distinct ratio of the nucleus in proportion to the overall cell size. And in neoplasia, the nuclei become disproportionately increased relative to the overall cell size compared to benign cells. As alluded to in the previous slide, accompanying cellular pleomorphism is nuclear pleomorphism. So the nuclei in neoplasia, especially malignant tumors, is more pronounced. The nuclei are increased in size and show much more variation in their shape compared to normal cells. Accompanying this are irregularities in chromatin distribution. So the irregular distribution of heterochromatin versus euchromatin, and also the nuclei are more typically darkly staining, or what we call hyperchromatism. And finally, neoplastic cells may have abnormally large or prominent nucleoli compared to normal cells. Another hallmark of neoplasia is the histological recognition of mitoses, and this indicates a higher proliferative activity and increased cell growth in tumors. But remember, it doesn't necessarily indicate that a tumor is malignant or that the tissue itself is even neoplastic, because remember, way back with tissue repair and hyperplasia, you may have increased proliferative activity as a tissue attempts to repair itself, or you may have increased cell growth because of physiologic or pathologic hyperplasia. But one thing that is distinctive about malignant neoplasia is the presence of atypical mitotic figures. So these are mitotic figures that may be tri- or multipolar, or have bizarre metaphase figures. And these are an indication of profoundly disrupted growth that you see in malignancy. So building on what we looked at with normal myometrium and a benign smooth muscle neoplasm, which we call leiomyoma, this is an example of a malignant neoplasm of the uterus called a leiomyosarcoma. And you can see, number one, that there's a lot more cells compared to the leiomyoma and normal myometrium. If you want to pan back a few slides, the nuclei are much more dark. These are all taken at the same magnification, so you can compare. The nuclei are frequently overlapping, so there's a loss of the normal spatial relationship. They're kind of crowded and jumbled up upon one another. The nuclei are much more dark or hyperchromatic, and the arrow points to an abnormal mitotic figure. So not only are the number of mitoses increased, here's another mitosis over here, so the number of mitoses is abnormal, but more importantly, we find these atypical mitotic figures. So all of these factors are taken into conjunction when we make the diagnosis of leiomyosarcoma, or malignant smooth muscle neoplasm of the uterus. Now remember that a tumor is more than just the parenchymal cells making up the tumor. It's also includes the tumor stroma, and there's changes in the tumor stroma that are also associated with malignancy. These include hemorrhage. Remember, tumors form new blood vessels to supply itself, but these vessels are abnormal and leaky, and these can leak red blood cells. Another feature is fibrosis, which we call in tumors desmoplasia, and this is where the stromal microenvironment is remodeled. It's important to note that the same molecular pathways that are associated with wound healing and scarring are operative in neoplasia as well. Finally, necrosis is another hallmark of changes in the tumor stroma associated with malignant neoplasia. Tumors often outgrow their blood supply and undergo, in a sense, ischemic necrosis. Also, malignant cells have altered metabolism, and there's a disruption in the balance between growth and apoptosis, or regulated cell death. So this is an adenocarcinoma that's associated with what we call marked desmoplasia, or scarring. So these are the malignant glands themselves, all in this slide. I don't need to circle all of them. But what's important is that what's in between, or the changes in the tumor stroma. And you see this dense eosinophilic material, which is all collagen, and the tumor itself is producing scarring, or desmoplasia. Now here's some other concepts that are associated with general features of neoplasia, and that's metaplasia and dysplasia and precursor lesions. So I'm going to talk a little bit about this. Now metaplasia you've already seen and heard about before. If you remember way back about a year ago, some of the general cellular changes that occur, and we've also touched on several different metaplastic entities throughout the last year. So if you recall, metaplasia is a reversible change in which one differentiated cell type is replaced by another cell type. Now often this represents an adaptive response in which there's a change in the environment that the cells are in due to some particular stress, and the native cell type is replaced by another cell type that is actually better able to withstand the adverse environment. And one example of this that you've already learned about is Barrett's esophagus, in which squamous epithelium of the lower esophagus is replaced by columnar epithelium similar to that normally seen in the gastric cardia in response to gastric acid reflux and inflammation. Now, the problem with metaplasia is that it may influence, or the influences that predispose to metaplasia, if they persist, can initiate malignant transformation in metaplastic epithelium. If you'll recall, we talked about Barrett's esophagus being associated with an increased risk for adenocarcinomas arising at the gastroesophageal junction. And so we'll see several examples of that, or of this process, as we talk about tumors in the oncology block. So we talked about metaplasia, and we've been talking about neoplasia. Let's talk about dysplasia. Now this refers to abnormal cellular growth and differentiation. Now it hasn't, these changes have not progressed to the point that the cells are independently growing, that is, they're neoplastic, but these changes often indicate an early neoplastic process. However, these changes are reversible and do not inevitably lead to malignancy. This term is typically used when the cellular abnormality is restricted to the originating tissue. So probably the most well-known example is the presence of dysplasia in the uterine cervix, which is associated with HPV infection and serves as an indication of neoplastic transformation of these cells by HPV, human papillomavirus, but at least in mild and sometimes in moderate or even severe cases of dysplasia, it can still be reversible. So it doesn't inevitably lead to malignancy, but is just a sign that there's a process in place that could lead to that. So that was the whole revolution that was introduced by the Pap smear and the identification of dysplastic cells before they became malignant. So, as implied, dysplasia shows a range of increasingly disrupted growth and differentiation or maturation with epithelial surfaces from mild to severe to what we call in situ carcinoma, which is a basically pre-invasive neoplasm when the dysplastic changes are marked and involve the full thickness of an epithelium, but the lesion hasn't acquired the properties that allow it to invade through the basement membrane yet. So this is a pictorial walk through the varying grades of dysplasia of the uterine cervix, which is the best example. And here we have mild dysplasia, so this actually is the business that's going on, and these cells are more hyperchromatic than normal epithelium, which you can compare right beneath here, and they're more jumbled up and disrupted, so they're not showing maturation to the surface. In addition, which you learned about in sexuality and reproduction course, is the presence of these coilocytes, which are indicative of HPV cytopathic effects. Now, in moderate dysplasia, we have even more disruption and disorganization of the epithelium. However, there's still some evidence of maturation in the superficial part of the epithelium, so this part toward the surface appears more normal, but this part below shows disorganization. The cells don't show maturation, and they show cytological some cytological features of malignant cells like hyperchromasia and nuclear enlargement. Now this panel here juxtaposes normal epithelium on the right with severely dysplastic epithelium on the left, and you can see that the cells are even more hyperchromatic. They all appear the same from bottom to top, so there's no maturation, and it involves the entire thickness. So this is almost to in situ carcinoma. And the panel over here is just a higher power view showing an exaggeration of severe dysplasia. And the cells that are at the base of the epithelium are just as dysplastic appearing as those at the surface, so there's no maturation at all. And if you compare these cells with the cells that are normal, appear larger, they're more hyperchromatic, there's much more cells per unit area, etc. You could even, if you looked at even higher power examination, find mitotic figures all the way up toward the surface. So precursor lesions are sometimes spoken of in conjunction with dysplasia, but actually precursor lesions is a more general type of description and may include hyperplastic, metaplastic, dysplastic, or even benign neoplastic changes that are associated with a clinically increased risk of or progression to cancer. So this is a less specific term. Another general feature of neoplasms is invasion. Benign neoplasms grow more as cohesive but expansile masses that remain localized to their site of origin. So these tumors specifically lack the capacity to invade surrounding tissue and blood vessels and, of course, metastasize to distant sites. Because of this expansile pattern of growth, they usually develop a rim of compressed fibrous tissue, which is called a capsule, that separates them from the surrounding host tissue. And so such encapsulation creates a tissue plane that makes the tumor discrete, readily palpable, movable, meaning that it's not fixed to the surrounding tissue, and thus it's more easily excised by surgery. So if we go back to our friendly example of the leiomyoma, you can see leiomyoma in the upper left-hand corner, and this is separated from the normal myometrium by this fibrovascular capsule. And actually you can see the ease with which the leiomyoma separates from the surrounding myometrium by evidence of these clear spaces, which is even in making a tissue section, the tumor separates a little bit from the normal myometrium because of this fibrous and vascular capsule. The invasion that we see with malignant neoplasms is different. Malignant neoplasms are poorly demarcated from the surrounding normal tissue, and a well-defined cleavage plane is lacking. So most malignant tumors don't recognize normal anatomic boundaries and show irregular infiltrative borders or an invasive front. And this characteristic is actually what gave the name cancer based upon its etymology relating to crab-like, meaning that the tumor has arms that are extending out into the surrounding tissue. Now you can have slowly expansile malignant tumors, and they may develop an apparent fibrous pseudocapsule because they push along a broad front into adjacent normal structures, but it's not a true capsule like we see with benign tumors. Other than metastases itself, invasiveness is the most reliable feature that differentiates cancers from benign tumors. So in this example of a leiomyosarcoma that is actually extending to invade the vaginal mucosa, we see a distinctly different edge to the tumor compared to the leiomyoma. Even though it forms a broadly invasive surface, you can see that in between lobules of invasive tumor is the surrounding stroma. So it's poorly demarcated from the surrounding tissue and is extending to a place where it ought not to be. So normally we don't find soft tissue like the myometrium adjacent to the vaginal surface, another abnormal feature. This is an opened colon specimen showing a tumor that's outlined in red, and you can see the invasive edge of the tumor into the surrounding wall. So if we compare the wall of the colon that's adjacent to benign mucosa down here, you can see the muscular layer here, the mucosal surface here, but in the malignant area this distinction is lost as we have tumor invading into and through the wall and into the surrounding fat, which is demarcated from the normal bowel wall here. Now it's much easier to recognize this microscopically because we don't see normal colon wall at all, and all we see is the and this also shows some other histologic hallmarks of cancer. We see there's no normal epithelial surface. It's all ulcerated. It's all ulcer-based. There's no muscularis propria layer. It's completely the wall is completely replaced by these malignant glands and nests of cells that are invading from the surface through the bowel wall and into the surrounding adipose tissue. So there's no normal colon here. So this is showing several microscopic features of invasive cancer. Now, as I mentioned, sometimes malignant tumors may show a broadly invasive pushing type of border rather than a raggedly infiltrating crab-like growth. And so we see this lung tumor that's pushing out in all directions along a broadly invasive front. But if we looked at this microscopically, we would not see a tumor capsule, but just tumor abutting normal lung parenchyma. So finally, let's talk about metastasis. This describes the spread of a tumor to sites that are physically discontinuous with the primary tumor. And so this distinguishes it from invasion, in which there's spread of the tumor in continuity to adjacent sites. So this is the unequivocal hallmark that makes a tumor malignant. Now, dissemination of cancers may occur through several different pathways or mechanisms. One may be direct seeding of body cavities or surfaces. So this is where seeds of tumor, if you will, exfoliate from the tumor and then just travel within a body cavity to implant into a distant site. Lymphatic spread is where the tumor must invade a lymphatic channel and then travel to a distant site, invade back through the lymphatic channel, and establish a colony, a tumor colony, in a distant site. And similar mechanism with hematogenous spread, only the vessel this time is a blood vessel. So the biological properties of invasiveness permits these tumor cells to penetrate blood vessels, lymphatics, and body cavities, and provides the opportunity for spread. Now, by definition, all malignant tumors can metastasize, but some do so very infrequently. This is reflected in their clinical behavior and the survival rates and so forth as we look at the prognosis and compare the incidence of tumors with the number of cancer deaths per unit time. So this is an example of a papillary thyroid carcinoma, and this is a section of the primary tumor located in the thyroid gland on the left. You can see that architecturally it forms these finger-like projections, which we call papillae. And this is a lymph node metastasis on the right. You can see the residual lymph node that's here in the lower right-hand corner. And similar morphology when you compare the metastasis with the primary tumor. So that's one way we know that that the metastasis has come from the thyroid carcinoma. Another example of a lymph node metastasis, remember we saw the colon adenocarcinoma a few slides ago, and this is an example of a metastasis, again, to a lymph node. So this, you get a bigger scope of the lymph node itself rather than a little corner piece from the previous slide. And similarly, you can see metastases to distant organ sites. This is revisiting the leiomyosarcoma. This is hopefully recognizable to you as lung on the left, and this is the metastatic leiomyosarcoma here on the right. You can see some of the histologic similarity to the leiomyosarcoma. This is a little bit low power view, so we don't really have the same high power view of the malignant cells themselves, but hopefully you can recognize these lobules of spindle cells like you saw in the previous slide of leiomyosarcoma. So this is a summary slide for you outlining the characteristics of benign and malignant neoplasms according to the different characteristics. And these are really the important points that we use to help distinguish between these neoplasms. And now you can too, be a junior pathologist. So hopefully this was a nice outline for you, the general features of neoplasms. Keep these general features in mind as we discuss specific tumor types as we move through the tumors of different organ systems. Thanks.